Hello, I'm Karin Moniz, the Technical Director at ICCBBA, and I'd like to welcome you today to our webinar entitled Move Beyond the Label with the MPHO Unique Identifier. Some things to think about as we delve into this topic today is how familiar are you with IT concepts like FHIR, Fast Healthcare Interoperability Resource? Does your facility have an HL7 FHIR project in the works? If so, what is it? How is it going? Are you already aware or familiar with the MPHO Unique Identifier? Have you heard of it before? Do you know what it is? Has your institution implemented it in any way? We'd love to know. Have you helped the concept move forward by submitting feedback, for example, on the biologically derived product on the US CDI submission? I'll tell you more about how to do that later. Before we get started, I'd like to let you know how to ask questions. Please submit them throughout the course of the webinar. You will see an arrow at the upper right-hand part of your screen. My arrow is facing to the right. Yours is most likely facing to the left right now. You want to click it open. It'll ask you your name, and then you should be able to see the Q&A entry portal. Erwin Cabana, our technical manager, will be fielding those questions and collating them for the question and answer session that will follow after all the speakers are done. Our agenda for today, I am so delighted that Mandy O'Leary from Moffitt Cancer Center will be joining us to talk about the patient safety impact of the MPHO Unique Identifier. You'll get to hear a little bit more from me on the description and use of this identifier, and Geoff Browne from StemSoft Software will be speaking to the need for the implementation. Erwin Cabana, our technical manager at ICCBBA, will be hosting the question and answer session. The objectives for today, and yes, I'm going to read them, are to describe why traceability and biovigilance are important, to describe the impact of a unique identifier and standardization on patient safety, to develop an understanding of how the MPHO Unique Identifier is constructed from elements on an ISBT 128 label, to explain how the MPHO Unique Identifier can be used in the electronic health record and in electronic messaging to convey additional information that is not on the label, and to describe options available for the electronic exchange of information about medical products of human origin. I hope you'll stay tuned for all three speakers in the question and answer session. This is a topic we've been moving forward for the last several years. I'd now like to welcome Mandy O'Leary to discuss with us the impact that a unique identifier for medical products of human origin can have on patient safety.
Hello, I'm Dr. Mandy Flannery O'Leary, and today I'm going to discuss how we can use the MPHO Unique Identifier to impact patient safety. So to draw a comparison, how many of you would consider yourself an animal person? So the picture here is of my three sheepdogs, Max, Ollie, and Pip, and these three are as important to me as my own child. So some people will do anything for their animals, and industry spending today shows that we are spending an increased amount of money caring for our pets. So when anything comes up that can affect the health of our pets, the media is quick to report it and share details about what's been affected and how it can affect your pets. You may get email notifications, hear about it on the news, or see information from social media sites. So let me ask, how quickly are you notified, or how much coverage is in the news when something happens in the human healthcare supply chain? Is it advertised as much as alerts for our pets? And shouldn't it be? So one of the biggest challenges with notifying the public or patients of an issue is having a unique identifier available for chain of custody of some of the products used in healthcare. Due to lack of standards, it becomes difficult to trace what went where or to whom. So today we're going to address the medical products of human origin. These are products that are used for a clinical purpose and are derived wholly or in part from donated human biological materials. Some examples are blood products, solid organs, tissues from either live or deceased donors, cells that might be used in cellular therapy such as CAR T therapy or stem cell transplant products. And these might be related versus unrelated as far as the donor source. Breast milk, fecal microbiota, and human derived plasma factor concentrates are all examples of MPHOs. So MPHOs have also been referred to as SOHOs, or substances of human origin. Per most regulatory bodies, the medical products of human origins must be traceable from collection to disposition. So some reasons for this include biovigilance or hemovigilance. This includes safety of the blood supply. So currently, there is a hemovigilance program in the United States, but some of the weaknesses that have been identified is that it's a passive surveillance program. The reporting is very manual and labor intensive. And then furthermore, the reporting is voluntary in most states. Because of this, very few hospitals end up participating, and that leads to decreased data. And without good data, it's more difficult to identify issues or track any problems. Another thing is product tracking in case of recall or lookbacks. So if proper tissue tracking or proper following of these products exists, it would allow faster and easier tracking of what tissues started where and who they ended up going to. And collecting that data in a standardized fashion gives us more access to figuring out potential problems in the field. So for example, in the UK years ago, they had a more standardized hemovigilance system. And by tracking plasma products, they were able to find a relationship between TRALI, or transfusion-related acute lung injury, and plasma products from multiparous females, or women who'd been pregnant multiple times. And knowing that information, we have been able to abate the TRALI reactions across the world at this point. Another reason for traceability is the inventory. So what happens if there's a mass casualty event, or if there's a big emergency event like a natural disaster? What blood do we have where, and how are we going to allocate and move our resources efficiently to care for everybody? Or for tissues, one donor can donate up to 90 tissue products. If those go to 90 different patients and something is found out to have happened with that donor, how are we going to be able to identify and notify those recipients quickly so as to prevent adverse patient events? So in order to do that, we really need a standard way to identify the products and follow the products. And currently, the lack of standardization in identifying MPHOs in computer systems and interfaces prevents this faster identification and notification of donors and recipients, which in turn could prevent adverse events and help with patient safety efforts. So some examples that have been cited in the literature include a study from about 10 years ago that looked at turnaround times tracking transplanted tissues in the United States. So when a tissue bank issued a recall of the donated tissue, they figured out that the mean time it took to locate and notify the physician who performed the tissue transplant was 13 days, but the mean time it took to actually locate and notify the patient who received that tissue was almost a month. They found that the lack of common coding and nomenclature was one of the key challenges in tracking tissues back to the recipient. So this study suggested some changes that could improve timeliness in the event of a recall, such as standardized tissue nomenclature and coding through unique donor identifiers, and using tissue traceability similar to how we use ISBT 128 in blood products. Another study in 2017 focused on a mycoplasma infection. So there was a donor who donated amniotic tissue, and then that amniotic tissue was made into 27 product vials from that donor. That tissue was distributed to 7 different states for patients to be used in spinal surgery. So of the 20 plus vials that were made from this donor, they were used in 14 patients, and almost 30% of the patients developed surgical site infections. What was pretty scary was the final disposition of 5 of the vials that were made were not able to be identified or confirmed. And that's pretty scary considering transmission was already documented in other patients. Another recent outbreak that was popular in the news a couple years ago was a tuberculosis outbreak in the United States. So while tuberculosis is known to be transmitted commonly in solid organ transplant, it really hadn't been documented until that point in tissue transplants. And in this particular case, there was a donor who had unrecognized risk factors, symptoms, and signs consistent with tuberculosis, and he gave a deceased donation of bone product. And that bone was processed into 154 different units that had live cells, and that went to 37 hospitals in 20 states in the United States. Almost 90% of those were implanted into patients in 18 different states. And unfortunately, 87 of the 113 identified recipients did have evidence of a tuberculosis infection, and 8 of those product recipients died after the product implementation. So in this particular study, there was donor-derived transmission of the tissues of tuberculosis in those tissues from that bone graft, and that resulted in substantial mortality and morbidity. So this shows yet another example why improved traceability of MPHOs are so important. And finally, I'd like to discuss another recent report that just came out a couple months ago describing post-transfusion sepsis from bacterial contamination in platelet collection sets in the United States. So despite platelet products undergoing bacterial risk control strategies such as primary culture or pathogen reduction and secondary rapid testing, there are still transfusion-transmitted sepsis cases back in 2018 to 2022. So even with these bacterial risk control strategies, it's a good idea for clinicians to maintain awareness of possible transfusion-transmitted disease with MPHOs, even when using these strategies. So in this particular case, there were 7 sepsis cases from 6 different platelet donations in patients in 6 different states. And unfortunately, of those cases, 3 patients died. So cultures were identified, and the bacterial contamination was confirmed by whole genome sequencing of environmental isolates from manufacturer of the platelet sets. And the testing and identification took a really long time. Had MPHO traceability been available back then, we may have figured this out sooner, leading to fewer patient adverse events or deaths. So although the MPHO supply is relatively safer than ever, because you hear us as clinicians say the blood supply is as safe as it's ever been, yes, adverse events still happen. So in these cases, we need to be able to identify involved products in patients as expeditiously as possible to minimize patient harm. To help do this, we need to have a single data item that includes critical traceability elements for use in electronic messaging and electronic health records. The MPHO unique identifier exists and will allow us to do this. Each medical product of human origin labeled with the ISBT 128 standard is globally unique to help us trace these products worldwide. So if we implement this as a standard and update our IT systems and vendor systems to consistently store this identifier, we can be more consistent in identifying medical product of human origin adverse events in case there are any issues. Currently, unfortunately, MPHO traceability is not consistently stored in a standard manner in electronic health records. So it makes doing recalls and lookbacks take more time, and because MPHO traceability is not consistently stored in a standard manner in electronic health records, it's more difficult to quickly identify the donor and the recipients of said products in case there are adverse events and we need to find those patients. So Karin Moniz will be discussing this more in the next segment, and thank you very much for your time today.
I'm back. Once again, I'm Karin Moniz, the Technical Director at ICCBBA, and I'm going to be discussing the development and the description of the MPHO unique identifier. But first, a little bit about ISBT 128. It is the international standard for the transfer of information associated with medical products of human origin. The system provides a globally unique donation numbering system, an internationally standardized product code definition schema, and a standard data structure for both barcoding and electronic data exchange. This could even extend to things like RFID encoding of this information with this standardized structure. It is essential for global biovigilance of MPHO. This ability to bidirectionally trace to and from the donor and recipient is critical. What are the images on this page? The pyramid in the upper left-hand corner is our information environment. that we use throughout our process to develop and maintain the standard. And you'll see that standardized terminology, which we addressed in a previous webinar, is the base of this pyramid. And then we go up from there, whether we're talking about labeling or electronic data transfer. The image on the lower left is the USS Comfort, and that is to remind me to tell you about the origins of the ISBT 128 standard. In the early 90s, a desert storm was occurring and blood was pouring into that war area from many, many areas of the world. And because there was no global unique donation identification system, they could and they did receive products that had the same donation identification number. And if you're a blood banker, you realize just how scary that can be in your record keeping system. Therefore, the need for a globally unique donation numbering system was realized. And along with that came this standardized terminology. So ISBT, the International Society for Blood Transfusion Working Party on Automation, was tasked to generate a new schema for this, and ISBT 128 was born. It was quickly realized that an organization was going to be needed to continue the development of this standard as well as maintain it. That's where ICCBA enters into the picture. ICCBA was established in 1994. We do develop and maintain the ISBT 128 standards for terminology, unique identification, labeling, and electronic data exchange for MPHO. Our standards and implementation guides are not developed in a vacuum. They're developed with the aid of our many wonderful volunteers via our technical advisory groups. You can learn more about them from our website, and both our other speakers today are members of these technical advisory groups and actively involved with the standard. ICCBA is an international, nonprofit, non-state actor that is totally supported by user fees. There's an ever-increasing global adoption of ISBT 128. I update this slide every year so that we can see that the slope continues to go up as far as active facility identification numbers, which identify each facility that is using the standard. There's an ever-increasing global adoption of ISBT 128, as you can see by the continuous upward slope for both facility identification numbers and product description codes, two of our key items that we issue. Moving on to the purpose for today, the MPHO unique identifier purpose. Medical products of human origin, abbreviated MPHO, are anything that comes out of one human being that is used medicinally in either that same or another human being. The purpose of the MPHO unique identifier is to provide a single data item that will facilitate traceability and biovigilance for each MPHO. What are the elements that are critical to the unique identification of an MPHO? It's the donation identification number, the product description code, the division identifier code, and the processing facility code. Why does moving beyond the label matter? MPHO will always be labeled. You need to have something physical attached to the product you're going to be using that describes it. The label will always be with us. But moving beyond the label enables us with the ability to provide additional information that is not on the label, to transmit information independently of the movement of that MPHO. We could potentially add information that's not currently on the label to be recorded about this MPHO. We could provide the inventory status. We could have a data warehousing scheme that incorporates this. We could provide adverse event information. It makes it more easily reportable if we had this unique identifier for the product that was used. How does the MPHO unique identifier help us move beyond the label? It is a single identifier that uniquely describes any MPHO in a standardized structure. And this becomes, if you will, the coat hanger that additional information can be attached to. So we have this MPHO unique identifier that combines those key elements of traceability I spoke about before. One of those pieces of information that we could attach is red cell antigen information. You see here two different labels. The one on the left utilizes the 2D data matrix symbology. That is actually starting to happen in parts of the world. And you can see how nice and clean that label is. But you can see that this unit is negative for several red cell antigens. The label on the right is the label that's more commonly used. And you can see that red cell antigens can also be encoded onto this label. We can send this information via an electronic message now. Okay. This is an XML example. This is now also possible with HL7 FHIR. And so we have the coat hanger near the top of the message that tells us that this is this particular MPHO. Okay, that's the MPHO unique identifier that combines these key elements. And you'll see down at the bottom that we have these red cell antigens listed along with information such as what type of methodology was used to test for the antigen. Is this a historical typing? Has it been typed more than once? That kind of information is embedded in the coding for red cell antigens within ISBT 128. We can use this information to identify additional information electronically for a shipment. The label examples before showed how red cell antigen information can be displayed on a label. The linear barcode only details what antigen is there and whether it's positive or negative. To get the more detailed information, you need the data structure that's utilized in the 2D data matrix symbology. So even before we switched to 2D data matrix symbology, we could supply this information in an electronic message associated with the shipment. So here you see that on this coat hanger for this particular MPHO, we've identified that it is Cal negative, has been serologically tested, and tested once on a prior collection. So we haven't tested it this collection, so the receiving facility may need to retest. We can see that it's JKA negative. That was genotyped and tested at least twice on different collections, but this information is historic only. And the same goes for the S antigen status. So the receiving facility can utilize this information to determine what confirmatory tests they might need to do when they receive this product. There are additional use cases for the use of the MPHO unique identifier. We could be uploading inventory status for a particular MPHO, whether it's available or not. What is the blood type, if it has a blood type, if it's blood, what the expiration date is, things like that. We want to be able to have this information cleanly in electronic health record. We can say whether a product was implanted or transfused, was there an adverse event associated with it, what was the blood type, anything that you might want to attach to this MPHO unique identifier, you could build your system to do. The MPHO unique identifier development. The identifier was first established and published in 2018. It was contained within ICCBA's reference table 42, which is data references for use in electronic messages. It was realized as more and more folks got into the realm of potentially providing information electronically that we needed additional information on how this is constructed. So that was published in 2021 in a standard. What is the structure of the MPHO unique identifier? The data elements for it are sourced from multiple data structures that are routinely used on MPHO labels, those key elements of traceability. It is a standardized 29-character code. Here is an example. You can see things that are highlighted. We have the processing facility code that starts it out. That's not routinely used in blood, so that part of the series is often 0, 0, 0, 0 if it's blood. The next one is the product description code. That's always a 5-character code, as you know, in ISBT 128. We have then the ISBT 128 donation identification number, which identifies the donation that this product came from. And then we have a division code or identifier. And that's 6 characters because there are different ways within ISBT 128 to increment divisions because of the different needs of the different MPHO areas. Where are the details? I mentioned standard 26. This is where you find it. And there's a QR code that if you're very fast, you can capture with your phone. And if not, please just go to our technical library and look it up there. You might find a wealth of other information you're interested in there as well. A few examples. Here is an example of a typical red cell label, and you will see that there is no processing facility code. We've put zeros in because the FINP is not typically used for blood products. Then we have the product description code, in this case E0336. We have the donation identification number, and we have the division code that is contained in the 7th and 8th character of a blood product code. And in this case, it's 2 characters, so there's 4 trailing zeros. We have an example of a cell therapy label. Here, contained in the 2D symbol, we have a processing facility code. As you know, sometimes there's more than one entity involved in manufacturing the cell therapy products. We have the product description code, the donation identification number, and in this case, a division code when product division's data structure 32 is used, so you have more characters involved in this division identifier. Here's an example of a tissue label with these same elements, and the elements on it can be translated into an MPH, a unique identifier. This label does contain a processing facility code. Also, of course, contains a product description code, donation identification number, and in this case, the division code is pulled from the final 3 characters of the product description code. Collection products for cell therapy manufacturing. We have a processing facility code, not present here because the FINP was not designated on the label. We do have the cellular therapy product description code, donation identification number, and the division code, in this case, from the 7th and 8th character of the cell therapy product. The MPHA unique identifier indeed provides a unique key for each individual medical product of human origin. This facilitates streamlined searching, potential enhancements in biovigilance, and electronic messaging. What's the picture of the aspens for? Well, each aspen tree is glorious in its own right, uniquely identifiable, correct? But they're not actually individuals. They're all connected. Aspen trees grow by shooting out another tree. Okay, so this is all one organism. It's all connected. So if you can imagine that these are all from, say, a single tissue donation event, which generates a large number of products, they are all easily connected, trackable, and traceable if the MPHO unique identifier concept is applied. If the MPHO unique identifier is embedded within the electronic health record, it allows us to easily see that this patient has received a medical product of human origin. You can easily tell that there's aspen trees on this mountainside, right? The MPHO unique identifier facilitates interoperability of electronic health records. Health authorities in many countries are promoting interoperability of electronic health records. The standardized structure of the MPHO unique identifier enables interoperability between disparate systems. Once again, it is a single data element. It's optimized for use in the electronic health record and provides a standard format for both traceability and electronic exchange of health information across the spectrum of MPHO use. Mandy spoke briefly about traceability for consumer products. And the end of that traceability road is the consumer, right? Who's vigilant, who's aware, who pays attention. We need a mechanism to easily identify that a patient has received an MPHO and what that MPHO is. The way to do that is this standardized MPHO unique identifier. How does it facilitate traceability? Repeating myself, the MPHO unique identifier is a single data element in a consistent format for all MPHO labeled using ISBT 128. This data element can be used as the final step in the traceability pathway and one that can make future lookbacks much more efficient. What are some of the current initiatives? HL7 FHIR. We, along with other organizations, have been working closely with their Orders and Observations Committee to enhance the biologically derived product resource that was in Release 4 as a shell structure. I'm pleased to report that Release 5 was published in April 2023 with a significantly enhanced biologically derived product resource. If you're a developer, dig into it, see what you can do with it. I spoke earlier about how healthcare authorities in many countries are encouraging interoperability of the electronic health record. One of those initiatives in the United States is the United States Core Data for Interoperability. There is an element there for the biologically derived product class. It is a comment level 2, but it's now been accepted for USCDI Plus, which allows for further testing. But we need everybody attending this webinar to go add your voice to the comments. I'll describe how to do that. So, how do you add a comment to the USCDI? It's fairly straightforward. To add a comment, you must have a login. An individual needs a login. They can be making their comment on behalf of an organization, and if so, they should say that that's what they're doing. So once you have a login, then you can search for the data class of biologically derived product and add your comment. It's fairly straightforward. If anybody needs me to walk them through how to do it, because it did take me a few minutes to figure it out the first time I added a comment, then please reach out to me. How do we get there? How do we move this concept forward? Seek opportunities to influence data standards, such as HL7 FHIR. In the United States, look at the United States Core Data for Interoperability. If you're from another country or are aware of another initiative that details information that should be going into electronic health records, please let ICCBA know about it, and so that we can work with you to help push the concept forward. We need to be asking developers of electronic health records to incorporate this unique identifier. If you think about it in the whole scope of medicine, right, MPHO is a niche area. But because these products come from human beings and can transmit diseases, among other things, and have other adverse events potentially associated with them, traceability, biovigilance is extremely important. So we need to let the developers of electronic health records know that this is a need. Biovigilance. I am repeating myself here. Current tracking of adverse events is hindered by the lack of easily extracted identifiers in electronic health record systems. We don't have those golden aspen leaves saying, hey, this patient received an MPHO. No. The MPHO unique identifier facilitates automated reporting on MPHO use. References and additional resources. There's a lot of information available on this topic on the ICCBA website. The standard 26 is there, as well as an implementation guide to how specifically to construct this identifier. Several articles have been published on the MPHO unique identifier and electronic messaging. We have documentation of difficulty in tracking and tracing items because we don't have this door-to-door or donor-to-patient bidirectional traceability firmly entrenched. And it's usually that last mile, that last step of getting the information in the patient's record that's most significant to this traceability effort. The impact of standardization. It's another one of my Colorado pictures. This is a petroglyph located on the Palisade Rim Trail in Colorado. It's beautiful, isn't it? But without definition, standardization, and harmonization of what it actually means, how can we even know what it means? Was this a pet? Was it just a beautiful thing? Was it dinner? We don't know. This is why we need standards to describe things that are being placed into electronic health records. Vendors, if you are using the ISBT 128 system for your products, any vendor-supplied material, any vendor-supplied software should be registered with ICCBA as well. To find a licensed vendor, please go to our website. We have a handy-dandy lookup tool. It's pretty nifty now and is going to be enhanced significantly in the coming year. We'll perhaps do another webinar to orient you around those enhancements in the near future. Without further ado, I'd like to introduce Geoff Browne, the Managing Director of STEMSoft, to describe from a software developer's perspective, why do we need to implement yet another identifier?
I want to start by thanking ICCBA for having given me the opportunity to speak today and for participating in today's webinar. It's really exciting. My name is Geoff Browne, and I'm the Managing Director at STEMSoft Software. I'd like to start by talking to you a little bit about my biases and why I think you should listen to me. So I'm biased, but I think that bias is relevant to the MPHO unique identifier. I've worked in cell therapy informatics for 28 years, doing a whole lot of kinds of work, from being a software developer to a software tester to an implementer into a whole lot of other different roles. Which means I've also been in an awful lot of facilities in that time, and I've seen a lot of the problems around exchanging data and information between facilities. I've seen those problems directly and from a variety of perspectives, again, from the point of view of a vendor. I also come from a background of a subspecialty vendor. That is to say, I'm not coming from a big EMR or EHR vendor where this is really a niche or a side portion of the operation, but rather someone where this is our bread and butter, our core focus. And so we can spend time concentrating on, I have spent time concentrating on exactly the kinds of problems that the MPHO unique identifier is intended to solve. In terms of specific experience that I think is relevant to today's presentation, I was part of the team that developed the first CIBMTR interface. For those that remember, that was the one where you mailed floppy disks into Milwaukee. I was part of the team that implemented the first commercial cell therapy ISBT label. In fact, I'm the one that designed our specification for that. And I was our product manager for both HL7 version 2 and HL7 FHIR interfaces. In other words, I have direct experience with the interfacing, the beyond the label portion of today's talk, as well as the label itself and the content around it. So that leads me to, why do we need another identifier? Because we have an awful lot of these things already. Why do we need more? In fact, when the MPHO unique identifier specification was first released, my reaction was, why do we need this? We already have this. We already have the donation identification number, the DIN. We already have the product code. We already have all these pieces. Why do we need them? And it took me a while to realize that we needed them because while we had these components, we didn't have a way to express them consistently, predictably, reliably for use beyond the label, for use in electronic messaging, for use in other connectivity. We needed to have a standard that told us how to use that standard effectively. Let me walk you through my thinking here. I want to start by talking about what problem we're trying to solve. Well, one of the biggest things that I hear about is wanting to be able to document the collection of a cell product and the infusion of that cell product in an electronic health record. Right now, we either can't do it or it's really difficult and expensive to do that. The other is exchanging matched unrelated donor product data between collection and infusion centers. So a lot of interest in being able to more easily share data, not just sending a label and accompanying documentation, but electronically exchanging information. And it's not easy to do that right now. Similarly, people talk about portals that are made available by the different commercial CAR-T vendors, for example, each of which requires data entry, often the same data entry, but multiple times for multiple vendors. How do we exchange data with those vendors and not have to re-enter it constantly into unique portals? And lastly, how do we facilitate novel cell therapies and relationships to those cell therapies? When I started out, I asked naively whether one would ever transplant from more than one donor into a single recipient. And I was told with confidence, you'd never do that, you'd kill the patient. And then shortly thereafter, the first double cord transplant was published. The world will change. Kinds and complexities of relationships and data around cell-based products are only going to increase, and we need a way to handle that effectively and safely. That means interfacing. That means moving data between systems. But interfacing today isn't plug and play. It's not something that we just connect. If there isn't a standard to describe what we want to do, that means we're going to have to negotiate. We're going to have each of the parties involved in the interface talk to each other and agree on a specification, and then implement or build something to meet that specification, then test it, then release it to you, then you're going to have to validate it. That's going to take a lot of effort. Maybe we do have a standard. Interfacing today isn't plug and play. It isn't something we just connect two systems to. If there's anything that does not have a standard, for which there is no published standard at all, then we're going to have to negotiate what that interface looks like. We're going to have to agree on what we're going to interchange, how we're going to interchange it. We're going to have to agree on all the pieces that involved in connecting two systems together, which can be substantial. Maybe we do have a standard for some or all of what we want to exchange. But if it's not for all of it, if it's just for some of it, if there's any variation allowed within that standard, then we're going to have to negotiate that variation. And again, agree on terms, document that, go away and build it, go away and test it, deliver it to you. You have to accept it. You have to qualify it. All of that has to happen every single time with every variation. Now, we can use standards like HL7 version 2. That's the ubiquitous standard for moving data between systems everywhere in the world. but it doesn't describe the content that gets moved. It describes the structure of a set of messages. It doesn't describe content. It doesn't tell us what values are allowed or not allowed. And it says nothing at all about cell therapy. There are no HL7 messages or HL7 content specific to cell therapy. Now, maybe that's okay, we say. We're going to use a proprietary interface. We've got everything built. Well, a proprietary interface is siloed. It means you, as the consumer, can only ever use that vendor's product because that vendor's product talks to that vendor's other product. You are locked in and have no more choices. And that means when you have another person you ever want to talk to, you better hope that they've also made the same choices you did. And every one of those things that I've just described happens again every time you upgrade, every time you replace a system, every time you add that new partner, that new CAR T vendor. You need to go through a negotiation yet again to make sure you can exchange data. And that makes interfacing costly. It's costly in terms of the obvious, money. You're going to spend money with a vendor. That vendor is going to develop or sell you an interface that maybe it's proprietary, maybe it's one-off. It's going to cost you money. It's costly in terms of time. If it's something you have to build from scratch, that time is spent writing a specification, deciding what you want to do. Maybe you won't get it right the first time, so you'll have to do it again. It's costly in terms of time of development and testing and release. All of that costs us time. And while that we're spending that time, that means things are happening to patients. That means things are happening in terms of new science, new technology, new partners are coming online. It's costly in terms of errors because these are one-off interfaces or there are variations that are unique. We are more likely to make an error because it's the first time we're doing something. Things that are used over and over and over again every day get tested in effect. Those errors are found and worked out of the system much more rapidly. It's been a very long time since I had an error connecting a mouse to a computer because that standard has been around a very, very long time. And it's expensive and costly in terms of compliance. If your interface is subject to, for example, CAP, you have to validate the results as they come across. The other issue with interfacing is within content is that if there's more than one way to do something, then we're going to find another and another and another way to do it. The list you see on screen is a subset of the number of different ways that I've personally seen for expressing an A positive blood type. Whether that's a single field or multiple fields. This doesn't even include every possible variation. You could have punctuation and spacing, making even more combinations. And for every one of those combinations, someone has to either agree on what you're going to use or map things. Everybody at ICCBA will recognize the last on my list, 62, because that's the ICCBA code specifically for an A positive blood type. The one above it is a LOINC code, which is almost as good in terms of being very explicit and very general. Everything else is human readable, but non-standard. And therefore, we can't anticipate it ahead of time, and we're going to get that many more variations in the data that we pass around, and variations means cost. Now, everything I'm describing so far, I'm talking about blood types, I'm talking about cell therapy products. We need a unique identifier because we're not very good at using these things in our systems. In 2016, it was really widely reported in the specialist tech press that at the Healthcare Information Management Society meeting that year, data had been presented that at Kaiser Permanente in Southern California, there were 10,000 patients named Maria Gonzalez, 10,000 people with the same first and last name. Further, it was reported that 8 to 14% of medical records included incorrect data because of incorrect patient identity. That could be transposition, that could be having picked the wrong person, that could have had the wrong ID interconnecting two records. 8 to 12% of hospital medical records were estimated to be duplicates. These are all relevant to this subject, to the MPHO unique identifier, because this is for something, a human being, that everybody understands. Everybody in the world understands what a person is. We understand that a person has a name, and yet we have significant error rates reported when trying to identify people. With cell products, we have more than one way within the standard that we can describe a split. There's multiple ways you can imagine to concatenate or combine the donation identification number and a product code. And even within those variations, to understand what you're looking at, you need to understand cell therapy or blood or tissue. You need to know the domain. So having a complex compound identifier, not having a single unique identifier for each product, introduces a very real risk of miscommunication, a very real risk that we can demonstrate by seeing that we already experience it with people. But we can mitigate that risk by having a single unique identifier, the medical product of human origin unique identifier. We need this because IT specialists don't need to understand the domain. We don't need anybody to be trained about cell therapy to understand that one thing has one ID. I can hire someone straight out of university and they can understand this is the ID for this thing. I don't need to explain anything else to them and they can start being productive. It means your IT specialists have one key that they can use to link objects so that they can make a connection between a person and a product. They need one ID for that product. They don't need to understand anything else. That makes queries cheaper and simpler and more reliable. It means that your software vendors don't need special search algorithms for identifying or making a match, I should say, between an incoming record and data they already have. We have one ID with a defined format, and we can reliably and predictably know that the message that we've received related to this specific product goes to this specific place in our database. It's not confusing. It dramatically reduces risk. And every one of those issues gets compounded every place that these data go. So every time you have a new partner, you have new data, you've got somebody else in your institution or outside your institution with whom you want to exchange data, you don't have to go through as much explanation to be able to get them to understand the data you have and consume it. I need you to understand a little bit about HL7 version 2. This is the ubiquitous user interface. This is the system that gets used to move data around your hospital. It's used everywhere on the planet. It's used everywhere on the planet because it started in 1987. It's a set of messages that use pipes and hats to delineate or separate content within the message. I'm going to tell you now that is not a common way to do things. That is almost unique to HL7 v2. The standard itself describes the structure of messages, but not content, security, or connectivity. It doesn't tell us how to talk to each other. It tells us how to organize our messages, but nothing else. It comes from an era when networks were static. Your hospital had a limited number of servers. You knew exactly what you had. You knew where they were. You weren't adding or removing things all the time. It was all very stable. It was designed specifically for moving data between two servers, between two major massive systems. So you could spend the time to negotiate all the specific details of content, security, and connectivity because it was all your stuff that was talking to each other, because it was mostly used for intra-organizational communication. This was for talking to yourself, to your own systems within your own hospital. So it works, but it requires specialized knowledge. It requires specialized tools. You have to learn those. Often the people that are specialists in this are quite expensive to hire. They know what they're doing. They have a lot of skills that are in demand within specific hospitals because this is not something that is generally available. It's a messaging only model, which means it's sending out a message. And if you're not listening for that message when it comes out, you're not going to hear it. So if I'm waiting to know about my patient being admitted, or I want to know if they were ever admitted, I better have been listening at the time that admission occurred, because once that's happened, I'm never going to see it again. Most importantly, for my purposes, it was never designed to be extendable or extensible. So it was never designed to allow it to grow in the way that healthcare really has grown. It has very limited support for subspecialties, absolutely none for cell therapy. You can't add additional fields. So if what you're doing changes through time, you can't modify the attributes of the message that you're sending. It does have this concept of a Z segment, which is meant to handle that scenario, but there's no mechanism for expressing a Z segment. So a site-specific segment is site-specific. It's not designed to be shared. So there are conflicts between different vendors. Epic and Cerner use Z segments differently, for example. So if you're a third party trying to consume messages from them, you're going to be dealing with data in different formats from those two vendors. HL7 FHIR was developed specifically to address these challenges. It was started in 2011, and it started with the assumption that a lot of the problems had already been addressed in broader web technologies. I won't go through what the sub-bullets are under open standards, but suffice it to say, this is the technology that your bank uses for electronic banking and online banking. This is the technology that Facebook uses, that Salesforce uses, that Microsoft uses, Google uses. These are already solving the problems of authenticating a person, of securing data, of making sure that we can connect to data from anywhere in the world. It was specifically designed not in an era of static networks, everything being in a hospital, but in an era when our assumption is that everything should be somewhere available on the cloud, that it should be accessible on mobile, that the Internet of Things is a real thing, that our devices need to be able to talk. It was built with all of those concepts in mind. And so it uses common web technologies. With HL7 version 2, I have to hire a developer and then train them. With HL7 FHIR, they pretty much come out of school knowing everything they need to know to start working with this almost within their first week. It's architecture agnostic, so it's not messaging specifically, but it can message. It can also be used for pulling data from systems. So for a subspecialty like cell therapy, your manufacturing or lab space can go and ask through FHIR, we have a patient, tell me what you know about this patient, and pull that data into your system. It's extensible and atomic. It's designed from the beginning with the idea that we don't need to describe everything in a message from day one. We need building blocks, Lego blocks that we can assemble to solve specific problems as we go. It's very focused around the implementer. So it's relatively cheap and straightforward to build this, implement it, test it, and know that it works properly. Most importantly, from my point of view, it's from day one had a ton of puns. Puns like, we're setting the world on fire, starting a fire under HL7, fire is catching on. Puns have been used from the beginning to communicate and help people get excited about this particular technology. So if you'll indulge me, we need the MPHO, the MPHO on fire. The image being of the pho I had for lunch. We need this standard because the MPHO unique identifier gives us, for the first time, a standard way to describe a cell therapy product and uniquely identify it in a way that an electronic message can consume easily and in a straightforward way, combined with HL7 FHIR that lets us, for the first time, talk about cell therapy and blood products in a unique and proper way. And that unique and proper way is the biologically derived product concept. So biologically derived product matters because it is literally the first standard to describe a cell-based product that's ever existed. Every time we've tried to do interfaces about cell products, we're having to use a drug message or a device message and kind of squint and turn our head sideways to try to find a way to make the fields that are specific to drugs work for cell products or blood products, and they don't. But here we have something specifically intended to support the description of a cell-based product. And that function is extensible to support future innovation. It's not restricted to a single donor relationship. It supports multiple donors. It supports multiple attributes. So you're not locked into one donor, one recipient, a volume, a CD34 count. We can do all that and a whole lot more. It also works with the existing building blocks in HL7 FHIR, the patient, the service request, the observation. A lot of these components that already exist that we don't have to invent or innovate, and that are already very widely and well supported already by big EHR vendors like Epic and Cerner. And most importantly for our purposes, it from day one supports the MPHO unique identifier. The other reason I think you should care about biologically derived product and FHIR is it's already supported by a whole lot of infrastructure that we're not used to talking about in healthcare. There's FHIR infrastructure support within Amazon Web Services. There's FHIR infrastructure support within Microsoft Azure, within Salesforce. And a whole lot of different really big tech companies have built this infrastructure in place to make it easier to exchange data safely and securely across the public internet or in private clouds. There's a whole lot of open source toolkits available for this as well. Those two things together mean the cost to build an interface or maintain the infrastructure on interfaces for HL7 FHIR is substantially lower than the costs and complexity associated with HL7 V2, which means we can actually interface data for cell therapy and other subspecialties. Because all of that infrastructure already exists, this enables global cooperation. We have a public standard. So a facility in Slovenia can exchange data with a facility in Ireland using a common standard that's well defined. The minimum amount of negotiation possible is required. Effectively, all they have to agree to is where they're going to connect. How and how they exchange data is already defined through the standard. I think this is the gateway to supporting biopharma, to getting away from proprietary portals that are specific to each, for example, CAR T vendor getting outcome data, and instead have standards compliant interfaces that means you can add an additional CAR T vendor without necessarily having to build anything new, that you can have a network of connectivity exchanging these data. And of course, it all supports the MPHO unique identifier. So we do need you, as you've already heard. I'm making the appeal to you as a software vendor to seek out opportunities to influence these standards to help them solve the problems that you're facing in your day-to-day. Work with HL7 FHIR working groups. They're really approachable. I've got a team member that's on the working group building biologically derived product. If you're American, influence the US CDI, because that is the key to getting the big EHR vendors to support these technologies, which in turn will make it possible for you to exchange data within your institution and without your institution at a much lower cost and much more efficiently. And in some cases, being able to do it at all will only be possible once those vendors support these kinds of common standards. And ask those vendors, ask the people that are developing electronic health records to incorporate the MPHO unique identifier. I know we already have, but we're a subspecialty vendor. This is all we do. Go out and talk to everybody else. Make sure that they're all on board with this, because ultimately it improves patient safety. It's a key towards improving biovigilance. It's a key towards making sure we can actually solve the kinds of problems that we're all facing. And if you are already working on a project around HL7 FHIR, around the MPHO, let ICCBA know. Particularly if you're outside Canada and the US, let them know, because this is an opportunity for them to come and work with you to help influence how that standard gets adopted around the world. I'd love to talk to anybody else that wants to talk about this stuff. The connection to my LinkedIn is on screen, so do feel free to connect to me there if you're at all interested. I appreciate your time. I'm going to hand things over to Erwin Cabana, who's the technical manager at ICCBA, for the Q&A session. Thank you.
Hello, I'm Erwin Cabana, and I'll be moderating the Q&A portion of the webinar. But first, I'd like to thank our speakers, Mandy O'Leary for explaining the impact on patient safety, Karin Moniz for describing the MPHO unique identifier, and Geoff Browne for explaining the need for its implementation. Keep in mind of the time here, it looks like we have time for just a couple questions, so let's get into it. So the first question we have is, could you compare and contrast the MPHO unique identifier versus the chain of identity identifier? I think, Karin, can you address this one, please? We didn't talk about the chain of identity identifier, but really brief background on it for those who aren't aware of it.
Sure, because that is one of the newer data structures on the block from ICCBA. So they were designed for two very different purposes. The MPHO unique identifier is not a data structure, it's a data element, and it's used to uniquely identify a single product by combining those key elements of traceability as we've described in this webinar. The chain of identity identifier was designed for a very different reason, and that is a linking number. Sometimes when, for example, in cell therapy, you need multiple collections of starting material to generate a course of a given therapy for a particular patient-specific therapy. So those are some real qualifier words there, but it's used as a linking number. So you're still going to have a DIN on each product, but you can use the COI identifier then to link those products, kind of like a master case file for everything associated with generating that given therapy that maybe, go through many manufacturers' hands and go through result in multiple doses. So I'll stop there, or else I'll give a whole talk on COI identifier, and that's coming.
Thank you, Karin. Next question we have is, what is the advantage of the MPHO unique identifier over the single European code? And if you don't mind, Geoff, since you're a software developer, maybe from that perspective, you can address that, please. Just unmute, please, Geoff.
No. I'll start, Geoff, you can chime in. So the single European code can employ ISBT 128 in the label. So part of the structure of the single European code is it needs a country identifier in the beginning. Okay, so that is a distinction from ISBT 128. But you can utilize ISBT 128 as one of the 3 allowable codes within the single European code. So if the product is labeled using the SEC code and ISBT 128, then you can still generate the MPHO unique identifier. And now we'll give it back to Geoff to finish up.
So can you hear me now?
Yes.
Okay. So we at work, we've implemented the SEC for our European clients. And that's the key thing why I think there's a distinction. It's only for European clients. Part of the SEC is you have to have a European facility identifier. And so it'll work for everybody in the EU, it'll work for people in Ireland, it'll work for people in Slovenia, to use my 2 examples from earlier, but it won't work for someone in the UK, it won't work for someone here in Canada, it won't work for someone in the US. So we need a global ID because we want to be able to send these products anywhere. And that is, to me, the single biggest distinction. Karen's point is also well taken. It has 2 different coding schemes that are supported. And if you remember my comments a few moments ago about negotiation, that means every one of you needs to be able to support both of those coding schemes to correctly interpret the SEC. That is not true here with the MPHO unique identifier. Everybody on the planet can understand it immediately, and we can implement a single system so a product can go from Singapore, it can come from Germany, it can come from Argentina. It doesn't matter. It will work everywhere, and that's why I love it.
Thank you. I'm trying to be mindful of and respectful of everyone's time. I know webinar is going a little bit over, so I'm sorry. That's about all the time we have for questions. So I want to thank our speakers for addressing those. But we'd also like to end the webinar with a final slide containing some further resources. So first, there's the ISBT128.org website. And we also have a help desk where you can submit any questions you have to support@isbt128.org. There are also 2 specific ISBT 128 standards documents that tie into the topics that were discussed today. The SC26 provides the specifications for the ISBT 128 unique identifier, and SC27 provides a dictionary of standard data elements that can be used in electronic messaging. You can also scan the QR code on the screen to sign up for ICCBBA newsletter, where we announce regular updates such as other upcoming webinars. So just to let you know, we will be sending out a follow-up with a link to the recording of this webinar and a list of the references that were mentioned throughout the presentations. I want to thank you all for attending, and this does conclude today's webinar. Thank you again.